There we go. So welcome to our coffee morning. We've got Michael here with us today. So he's a community involvement and engagement manager for the NIHR Global Surgery Unit. And he's going to be talking about the species study, which is about measuring the effect of surgical site infections on the quality of life among patients in low to middle income countries. So I'll hand things over to you now, Mike. Thank you.
Good morning, everyone. It's an honor to be here. Carmel and I used to work together when I lived down south. I'm based in the West Midlands. Is everyone familiar with PPI? Just does everyone know what patient and public involvement is? Great. And does everyone know what the NIHR is, the National Institute for Health and Social Care Research is? Great. So what some of you may or may not know is that the NIHR actually funds some global health projects, meaning projects outside of England. And they use a different term for PPI when talking about research done outside of the UK. So in the UK, we use the term patient and public involvement, or PPI. For NIHR studies funded abroad, it's called CEI, Community Engagement and Involvement, to emphasize the importance, at least in a lot of communities outside of the West, the importance of communities in patients' decisions when it comes to their treatment. And I'll mention a little bit more of this in the talk. So if I say CEI, please know that I mean PPI, but in a global context. So with that, I would like to greet everyone a good morning. I work for the Global Health Surgery Unit funded by the NIHR. I'll be talking about species, which is a study. It's technically not CEI or PPI, but it's informed by a lot of CEI that I'm personally leading. But I'll be talking about a few things before that. So the outline of today's talk, briefly, I'll talk about who are we. So who is the NIHR Global Surgery Unit? What work have we done so far? And what do we plan to do? Particularly, the two big PPI or CI projects would be the species study, as previously mentioned, and our development of the Community Surgical Site Infection Prevention Toolkit. So first things first, what is the Global Surgery Unit? So this is our photo from our annual meeting that was held in New Delhi in September of last year. And it's a collaboration of different countries in trying to improve surgical outcomes in low to middle income countries. So this is our second tranche of funding. So we initially got funding from 2017 to 2021, 6.9 million. And then in 2021, we got refunded for 7 million until 2026. We work with these following countries, so Benin, Ghana, India, Mexico, Nigeria, Rwanda, and South Africa. And we follow a hub and spoke model. So we collaborate with a government or university hospital in each of these countries, and they connect us with smaller hospitals associated with these government or university hospitals. And we meet every year, but we try to answer pressing questions that might not be an issue in the UK or in the West, but may be issues in terms of surgery in low to middle income countries. We don't really have well-defined research themes, and that's why the word themes has bunny ears. But the most important outcome that we are trying to prevent in low to middle income countries are surgical site infections. So a lot of the research and studies and trials that we do are focused on this. In light of COVID, we had to look at surgical delays in waiting lists. So the waiting list or problems with waiting lists don't just happen in the UK, they also happened outside of the West. And then we have special projects that we do in certain countries. So for example, Ghana is actually the country in Africa with the highest demand for hernia surgeries. That kind of makes sense because a lot of people do manual labor. Unfortunately, they don't have enough surgeons to perform this relatively simple operation. So the one study that we're really trying to push forward is what we call task shifting, where you allow certain health workers and you train them to do specific procedures. So in this case, we're looking into, can we possibly train GPs who perform cesarean sections anyway to perform hernia surgeries to a population that really, really needs it? And then in January, along with our collaborators at the University of Edinburgh, we got 7 million from the Wellcome Trust to develop training so that we can roll out keyhole surgery in low to middle income countries. So is it possible to shorten the training time of surgeons in low to middle income countries so that they can perform keyhole surgeries? Because we know that they're definitely safer. Patients heal much faster. So is there a way to actually deploy surgeons as fast as possible? And then finally, we got some funding to do this in the UK, and we're also applying for funding to try it out in low to middle income countries. Is there a way to have greener operating theaters? So if you may be familiar with the term carbon output, and that's how much carbon waste comes from different things we do, like maybe traveling or buying a certain food item, importing stuff. Within the hospital context, 30% of the carbon footprint of a hospital comes from an operating theater. And a lot of it actually comes from the use of anesthetic gases like desflurane. So what we're trying to find out is, are we able to somehow cut down on this carbon cost without compromising patient safety? So these are the big things we're doing. And just a few highlights of what we've done. So in 2021, the unit was awarded a Guinness Book of World Records as the largest scientific collaboration for a paper we published on waiting lists due to COVID. And that was published in the Lancet. So that's Surge Week. So that's the largest global cohort study in surgery. And then we also conducted the largest randomized controlled trial in surgery called Falcon. So what Falcon aimed to do was to look at the use of antibiotic-coated sutures for sealing up a surgical wound versus non-antibiotic coated. Now, in the West, in the UK, it seems it seems obvious that we use antibiotic-coated sutures. But the thing is, if you look at the evidence, there's very little evidence to prove that they actually work. And so what did we do? We ran this trial, I think, in 30,000 patients. And what we found out is that there's no significant difference between using antibiotic-coated sutures and non-antibiotic-coated sutures, which from an health economics perspective is actually quite good, especially if you are a low-resourced hospital. And then our latest paper, our latest big paper, was this largest cluster randomized controlled trial called Cheetah. So a cluster randomized trial. So normally when you think of a randomized controlled trial, you think individual patients either receiving the placebo or the treatment, right? A randomized controlled trial would be, a cluster randomized trial is when you treat a cluster of patients as either having the placebo or the drug. And now why would you want to do that? Well, in this case, Cheetah, it aimed to find out if changing surgical tools and gloves before you suture a patient after surgery actually works. Again, something quite obvious, right? You open up a patient as a surgeon, your gloves are bloody, change it before you suture the patient. But again, we don't have enough evidence to prove that it actually works. And so we did this trial where we randomized not individual patients, but hospitals. So either a hospital does the changing of the gloves or standard care. And what did we find out? Oh, so sorry, I'm going to skip this slide. What we found out with Cheetah was this. So we looked at 13,000 patients in 81 hospitals. And we found out that by simply changing gloves and instruments before suturing the patient, it can actually reduce surgical site infections by as high as 13%. So the next step, and we have a paper coming out now, because we work closely with health economists. Because again, for per patient, this might be maybe a 5 or 10 pound additional cost, because that's additional gloves and instruments. But if you look at the whole health system, that could mean millions of pounds. So what the health economists are trying to find out is if we spend a little bit more doing this, does it actually offset the cost of people getting a surgical site infection, staying longer in hospital, and not being able to work? So our health economics paper has been accepted, but is still going to be published, I think, in 2 or 3 months. So yes, so routine change of gloves and instruments does actually work. So those are the highlights, the big things that GSU has been doing. So these are the trials and studies that are currently ongoing or are finished within GSU. It's a veritable Noah's Ark. So that's why we named the studies and trials animals. What are a few highlights here? I don't have time to talk about everything. One would be Talon, this one here. Talon's quite interesting, and this was developed during COVID. So the challenge with dealing with patients in low to middle income countries, especially if they live in rural or very remote areas from a district hospital, is that traveling back for their follow-ups can be quite challenging and expensive. So what one of our PhD students did, and he's now a clinical lecturer, is he looked at what you call this wound healing questionnaire. So the University of Bristol developed a wound healing questionnaire, 10, 15 questions, yes or no answers that you ask the patient. And by simply looking at the number of yeses or nos, you can actually find out, even without looking at the wound, if the patient possibly has a surgical site infection. So what he did was to convert this wound questionnaire that's on paper into something that could be delivered over the phone. And it had a pretty good predictive value if a patient had a surgical site infection. Now think about it. Combine that with maybe video calls on phones, because India, for example, has really high penetration of smartphones. So almost everyone has a smartphone. They can make video calls. So if you combine that questionnaire with a smartphone, then you can actually avoid people having to spend lots of money to go to the hospital for a follow-up. So those are a few things that we're doing. So what do we plan to do? We have 2 important trials in the pipeline. The first one is called SWAN. And again, following our theme of preventing surgical site infections, this study or this trial wants to find out if we use regular dressings versus this special sore back dressing, which is routinely used in Europe. Can the sore back dressings prevent SSIs better compared to regular dressings? So that's one. It just wants to compare 2 kinds of dressings. And then the second one is called Dragon, which aims in keeping with the green surgery theme of the unit. Are we able to reduce surgical site infections if we use reusable operating drapes and gowns in theaters? So again, this wants to compare single use versus reusable drapes and gowns. And the main objective or the main outcome we want to prevent here are SSIs. So the big question is, will these interventions reduce surgical site infection rates? So where does CEI or PPI come into this? So far, all the data that we've collected from patients have been clinical data. It's either, do they have an SSI? Do they have any complications? Do they live or die, etc., mortality rates, etc. But so far, our trials have never collected quality of life data, meaning what is their experience of having an SSI, especially outside the hospital? Because we know, especially in low to middle income countries, where they may not have a social security net like benefits, for example, in the UK, if people are working and they develop a surgical site infection and have to stay for an extended period in a hospital, if it's a private hospital, they need to pay for it. But 2, they can't go on benefits because they don't have that system there. So they basically lose income. And that can have knock-on effects on their families, on their mental health. So we thought of maybe collecting quality of life data of patients. So again, delayed return to work, psychological, social, and financial effects. And also, we wanted to find out what levels of health literacy did patients have in terms of self-managing a surgical site infection? For example, do they know the signs if, if this wound smells funny and I'm at home, I should actually call my doctor? Do they actually know that? Unfortunately, most of the evidence we have on the knock-on effects of surgical site infections come from high-income countries. There are quite a few papers from Scandinavia, from the UK, from the US, but none from low to middle income countries. So you're thinking, is it possible to collect patient quality of life data? And so the main objective of this is to compare quality of life data from patients who've had an SSI versus those who have not developed a surgical site infection. The whole idea being, if you did not have a surgical site infection, your quality of life, or at least the rate at which you rebound from surgery, your quality of life, will be much faster than someone who's had a surgical site infection. And then to assess, are they aware of how to self-manage an infection? So the whole idea is to invite participants of SWAN and DRAGON, the two upcoming trials, to this study. And we're going to be using this quality of life tool. It's a survey called the PROMIS Global-10 scale. This was developed by the US NIH in the 1990s. And the reason for this, for selecting this, quite a few. Number one, there are only 10 questions. We don't want to add more burden to staff on the ground by asking them to deliver the questionnaire that's maybe 40 questions long. Second is that there are actually quite a few translations available. A lot of the quality of life tools that we use, they usually have translations in Western languages. And while we do have a few Francophone African countries we work with, like Benin, they're a French-speaking African country, people living in rural areas don't really speak the Western language, especially if they weren't able to go to school. So it's important to have the necessary translations. And we're going to be sampling or surveying patients at 3 points in their surgical journey: before their surgery, pre-op, during discharge, and during their 30-day follow-up. Then following this, we look at the responses, we group them into themes. We then have selected interviews from patients, and then we write up a paper. And so this is how the tool looks like. It's fairly short. It's validated in a lot of countries, but unfortunately, it's not validated in a few low to middle income countries. This is free to use and to license. And then these two questions in these boxes, so there's a green box and a red box. These are additional questions that we will be asking patients. So this is not part of the tool itself, but questions that, based on our research, we will be asking patients. So questions about feeling unwell, worrying about their wound, worrying about taking care of their family, being the surgical wound being a cause of delay of getting back to work, etc. So we have all of this, but how did we come up with this? So we actually did work with patients. We did CEI on this, or PPI. And how did we do this? When this was being conceived, maybe July or June of last year, we consulted with stakeholders in 5 of our hub countries, so about 157. So from SSI patients to carers, community health workers, who again, these community health workers, if you do not know, are non-medically trained, trusted members of the community who are liaisons to a district hospital. So in a way, they're trusted members of the community, but they're also public because they're not medically trained. And then, of course, you need to consult with village chiefs and opinion leaders. And so we asked them, okay, what do you think of this study? Is it worth doing? Is the tool that we're using reasonable? And are there additional things that we should be asking? So what did we find out? So number one, we found out that, yes, they agree. Surgical site infections and its effects beyond the hospital are important, and they are a patient priority. So check. Next, they commented on the language of the survey. It's easy to understand, or at least translations of the survey. They're easy to understand, but there are some scientific terminologies that may not have local language equivalent. So it's important that the translations be done so that individuals, patients who might not have high levels of health literacy understand the survey. And then it's also important that once you get patient survey results, you educate patients. This is the engagement part of the PPIE. So you don't just say, oh, okay, their quality of life is really low because they have an SSI, but you need to go a step further and actually educate them on how to self-manage. So, few challenges. And then Carmel, how many more minutes do I have? Because I can cut this short if people are bored with what I'm talking about.
No, I think, yeah, continue.
Okay, great. So, few challenges. So it's not been smooth sailing, I have to admit. The number one challenge we have is that the validated tool we're using does not have any translations in indigenous African languages. So these are a few of the indigenous African languages that we need to have. Unfortunately, those aren't available just because they aren't used in these settings. And here's the catch here, here's the kicker, which is quite painful. The translation process is quite lengthy and costly. So it's about 10,000 pounds per language. And it takes about 6 to 12 months to do. And it's for a 10-item questionnaire, 10 grand. So we basically have to prioritize which ones. So that's the reality of research. There will not be enough money, but you want to capture as many patient responses as you can. And then the even bigger question is, the questionnaire was developed in the context of the West. It was developed in the US. Will it even work in our populations? So those are the challenges. Now, we do have a plan, fortunately, and we do have a few next steps forward. Number one, we have submitted the protocol of this study to our research ethics committees, and we're waiting to hear back. The good news is the existing language translation. So we have, I think, 10 Indian languages. We have 2 South African languages. They have Spanish and French. All of those are license-free because the copyright holders are a university in the US. So the idea is we use those existing languages for free, and we check based on our initial results. Is this tool actually quite good at capturing patient responses? And if we think that it's good at capturing these patient responses, again, we're not going to be able to include everyone. We can then justify and say, oh, the tool is great, but we're not able to capture, let's say, 50% of patients in Benin because they don't speak French. Then we can justify, oh, okay, we definitely need to have an African language translation. And then essentially negotiate with the copyright holders any temporary translations we can come up with. So that's species. I'll briefly talk about, again, I'm trying to be aware of time. I'll briefly talk about the next step. So if you recall, I mentioned the community said, don't just capture responses from us, but teach us how to self-manage. And so as an offshoot of this, we got a small funding from the NIHR to develop a community surgical site prevention toolkit. So what is this toolkit? So we got 20,000 to spend on sharing the findings of our studies to patients and communities. Challenge with this, though, is that particularly for Cheetah, right? So Cheetah is the study where surgeons change gloves and instruments prior to suturing a patient. Really, at that point, patients don't have any say in that. They're unconscious. They're on a surgical, they're in surgery. They can't really tell a surgeon, could you change your gloves or instruments? So how do we make this finding a study that focuses on actions of the surgical team relevant to patients? So focus then would be, maybe it's important to raise awareness about surgical site infections and self-management of surgical wounds among patients. And so the whole idea of this toolkit is to develop a library of resources for patient education to be used by hospital staff and community health workers, and to make this continuous. So we don't just develop one version and it ends there. As needs arise, we come up with more resources. Now, the challenge with this, as you can imagine, is that if you're working with 6 countries, you have 6 different languages, but not just that, they all have different cultures, they all have different health systems. So how will you support all of these hubs doing this in parallel? So the whole idea is that each of the hubs identify different aspects of surgical care, surgical patient education that they want to develop. So initially we call these modules, but the whole idea is they develop a pack of different tools they can use to educate patients. So these could be on like what are surgical wounds and surgical site infections. So very basic. What are those? What are the signs and symptoms? And what do you do? Second would be, if they feel it's useful, what do patients who are about to undergo abdominal surgery need to do? And the reason for this is majority of patients in our trials are undergoing open abdominal surgery. If they're undergoing laparoscopy, they could develop tools on that. A lot of the patients in some of our hubs have stoma bags, and that will require self-management at home, or a colostomy bag. So how can you teach them how to manage that at home? Care after surgery if you have pre-existing conditions. So if a patient has, a healthy 21-year-old will have to take different precautions from someone who's 65 and hypertensive after surgery. Then PIP6 is your surgical journey. What this simply means is sometimes when patients are admitted to the hospital for surgery, they don't really know the process. They don't know, okay, what happens, for example, from admission to maybe doing pre-surgical assessments, the surgery itself, recovery room, and ward. So the whole process can be quite intimidating and confusing to patients. And so if you can actually prepare them before they get admitted and tell them this is what's going to happen to you, hopefully they have a better outlook at how their surgery will turn out. And if there are other aspects of surgery, for example, the one hospital in Rwanda that we work with, for some reason, they tend to do a lot of orthopedic operations because I think they're like the National Center for Orthopedic Surgery. So they want to develop specific patient information on orthopedic surgeries. So that's the whole idea. And the plan is to launch the initial version of this library of resources during our annual meeting this September in Lagos, Nigeria. That's pretty much it. Thank you. So this is a picture I have taken July of last year in Rwanda. This is me and a group of community health workers, and they're wonderful people. We couldn't understand each other. We had interpreters, but they're wonderful people. So I'm happy to answer any questions you have. Thank you so much for listening.